Nampak tak slide Prof?
Yes, what's wrong?
Nampak Kak.
Nampak Okay, can we start now? Okay, so Bismillahirrahmanirrahim. I'm going to present this seminar today regarding the neonatal jaundice. Okay, so this is my outro to the definition of jaundice. Second, we will go to the bilirubin metabolism, and later we're going to go to the approach to the neonatal jaundice. We will go to the history, physical examination, investigation, as well as management.
I cannot see the slides.
Okay, so first, what is jaundice? Jaundice can be defined as the yellowish discoloration of sclera, skin, and mucous membrane due to the elevation of the serum bilirubin.
Kejap Kak Syairah.
And
Kak,
it can
kejap.
be clinically detectable.
Kak Syairah.
Yes, Doctor?
Doctor, can you see the slide?
Nampak?
I can see now. Yes, yes, now I can see.
Okay.
Hello? Oh, yeah. Yeah?
Saya ada background noise.
Okay. Okay, so jaundice can be 85 micromole per liter or equal to 5 milligram per deciliter. Background noise. The bilirubin metabolism. So for the bilirubin metabolism, first hemoglobin is breakdown into the unconjugated bilirubin. This unconjugated in lipid. So this unconjugated bilirubin will bind to the albumin, and then it will be taken out by the liver. So in the liver, this bilirubin will conjugate with the glucuronidase transferase enzyme and become conjugated bilirubin. So this conjugated bilirubin is actually water soluble, and then this bilirubin will excrete in bulk into the gut. So it will be steatobilinogen in stool and urobilinogen in urine. However, if the unconjugated bilirubin exceed the albumin binding capacity, it can cross blood-brain barrier. It can cause the clinical risk.
I think the bilirubin metabolism, we need to show it more
Okay,
in
so
more
this is the
detail.
type of bilirubin. We have two types. We have
Shahira, for bilirubin metabolism, we need to go in more detail. Yeah, we need to show more detailed bilirubin metabolism because you made it simplified. Yeah. So let's see it in detail. Bilirubin metabolism is important, very important. So I want you to know in detail. Okay. No more bilirubin.
I think
Hemoglobin. The enzyme which creates hemoglobin. Heme oxygenase. Heme first hemoglobin heme
Red globin.
and so this goes to the amino acid ball. Amino acid ball. And here goes to heme oxygenase. Heme oxygenase. Heme oxygenase will give us biliverdin. Then we have, what is the name of the enzyme? Biliverdin. Reductase.
Reductase.
Very good. Reductase will give us bilirubin. So this bilirubin is unconjugated. This bilirubin is unconjugated. Unconjugated or indirect. Unconjugated or indirect. So it is lipid soluble. It binds to albumin. It binds to albumin. Binds to albumin. Then it goes to the liver. By the blood circulation, it goes to the liver. So in the liver, we have 4 steps. In the liver, we have 4 steps. Binding, uptake, conjugation, and excretion. So, binding to the receptors, uptake inside, conjugation with the enzyme, uridine, diphosphate, glucuronide transferase. Glucuronide transferase. That is the name of the enzyme. So, bilirubin becomes conjugated. Bilirubin becomes conjugated and excreted. After excretion here, when it reaches the intestine, when it reaches the small intestine, it will not stay conjugated. So what bilirubin is see here is not conjugated. There is enzyme intestinal deconjugase. Intestinal deconjugase. Deconjugase. This intestinal deconjugase will make bilirubin again unconjugated. So it became conjugated here, but after the intestinal deconjugase, it became unconjugated. It became unconjugated. The other thing can make deconjugation is bacteria. Bacteria also can act and make deconjugation of bilirubin. The bilirubin which is released here now, it goes for enterohepatic circulation. The unconjugated goes for enterohepatic circulation. Enterohepatic circulation. And the one which does not go into enterohepatic circulation becomes urobilinogen by action of bacteria. Urobilinogen, and then goes to the kidney, becomes urobilin. Urobilin. The part which does not go to the kidney, it goes down and becomes stercobilinogen. Stercobilinogen. And this stercobilinogen becomes stercobilin in stool. So we need to know it in detail. Is it clear for everyone?
Yes, doctor.
Okay.
Clear, bro.
Continue. Okay. Okay. Continue, Shahira.
Hello, nampak tak?
Tak nampak lagi. Tak keluar lagi.
Nampak lagi?
Assalamualaikum.
Okay, so now types of bilirubin.
Assalamualaikum. Doctor, can you please open at my
Yes, Shahira.
I cannot share the slide, so
Cannot share the slides. So
I ask help for Shazani.
okay. Ask the help. We can help you.
I've already asked Shazani for help to screen the slide. Check.
Okay, you share the slides and okay, fine.
Can everyone see the slide?
everyone can see the slide?
Yes,
Yes, Wani.
Yes.
We can see the slide.
Okay.
Okay. So next slide. Okay, so for the types of bilirubin, previous slide. Okay, so this is the types of bilirubin. We have two types. We have unconjugated bilirubin and conjugated bilirubin. So for the unconjugated, it can bind to albumin, and for the conjugated, it is conjugate with the glucuronic acid in the liver. And then for the unconjugated, it's a lipid soluble. For the conjugated, it's a water soluble. And for unconjugated, can cross blood-brain barrier. And for conjugated, can be excreted in urine and stool. And unconjugated, it can cause brain toxicity. And for the conjugated, it's not toxic. Next.
What do we call the toxicity in the brain? Kernicterus. Very good. Which part of the brain? Which part of the brain is affected by kernicterus?
Basal ganglia.
Yes, basal ganglia. Basal ganglia and the brainstem nuclei. So first basal ganglia, after that brainstem nuclei. Very good. Carry on.
Okay, next. Okay, so this is the causes of the neonatal jaundice. We can divide it into three. Jaundice starting at the less than 24 hours of life, jaundice at 24 hours to 2 weeks of age, and jaundice at more than 2 weeks of age. So for the jaundice that's starting less than 24 hours of life, so it can be caused by the hemolytic disorder such as rhesus incompatibility, ABO group incompatibility, T6PD deficiency, and as well as phagocytosis. But the most common is the ABO incompatibility. And second cause is the congenital infection, like torches. And then second, jaundice at 24 hours to 2 weeks of age, may be caused by the physiological jaundice, breast milk jaundice, septicemia, hemolysis, and as well as polycythemia. And then for the jaundice at more than 2 weeks of age can be divided into two, unconjugated and conjugated. So for the unconjugated, it can be caused by the breast milk jaundice, septicemia, infection, hypothyroid, and as well as hemolytic anemia. So for the conjugated, can be caused by the biliary atresia, choledochal cyst, congenital infection, inborn error metabolism, and as well as neonatal hepatitis. Okay, so neonatal jaundice can be classified into two, unconjugated and conjugated. So for the unconjugated, we have physiological and pathological. So pathological, we have hemolytic and non-hemolytic. Under hemolytic can be caused by hereditary spherocytosis, sickle cell disease, and as well as thalassemia. For the non-hemolytic cause, it is breast milk jaundice, sepsis, and hypothyroid. For the conjugated, we can divide it into hepatic and post-hepatic causes. Hepatic cause can be caused by the torch infection and as well as galactosemia. And for the post-hepatic cause, biliary atresia and choledochal cyst.
Okay, Shahira, I will ask you here. So in the hemolytic causes,
yes,
you put sickle cell disease. I don't know which reference told you that sickle cell disease can cause neonatal jaundice.
sickle cell disease.
What's the reference? Because as I know, sickle cell disease, yes, it is one of the causes of jaundice, but it doesn't cause a neonatal jaundice. So this one, it is better you cancel it. Huh?
I took it out from internet.
You take it from the internet. Which part of the internet?
Okay.
Because the internet, you know, it is open for everybody. Yeah, I prefer you cancel it. Cancel sickle cell disease. And when you say thalassemia, which thalassemia you talk about? Which thalassemia can cause neonatal jaundice? Which thalassemia? It is unusual also. It is unusual. It may happen sometimes in severe form of hemoglobin H alpha thalassemia. If you have 3 deleted genes, 3 deleted alleles. You know, if you have 4 deleted alleles, the baby will be born with erythroblastosis fetalis. Erythroblastosis fetalis, they will have this jaundice, erythroblastosis fetalis. If you have 4 deleted alleles, Barth hemoglobin, we call it Barth hemoglobin. If you have 3 deleted alleles, it will be hemoglobin H. It is unusual to cause neonatal jaundice, but it may happen. It was reported. Yeah. Beta thalassemia never. Beta thalassemia never causes neonatal jaundice. Better don't mention these things. You mentioned hereditary spherocytosis, yes. You mentioned ABO compatibility, RH incompatibility, yes. But like sickle cell disease and thalassemia, better.
Okay, thank you. Okay, so next. Okay, so for the physiological jaundice, usually in the newborn, it can be caused by the bilirubin metabolism is immature due to the liver immaturity for it to be metabolized by the liver, and as well as the increased bilirubin load on the hepatic cell due to physiological polycythemia due to larger circulating red blood cell volume and as well as shortened red blood cell lifespan, in which the neonate has 70 to 90 days red blood cell lifespan compared to adult, which is 120 days. Appears between hours of age, and then the maximum intensity seen on 4th
What do
to
you mean
5th day
between
in
hours
liter,
of
but
age?
usually does not exceed 15 milligrams
Tahira,
per liter. And
what
usually,
do you mean between hours of age?
yes,
What do you mean by first appears between hours of age? I don't understand. Which hours you mean?
I mean more than 24 hours.
Must be more than 24 hours because first 24 hours is pathological. Usually physiological jaundice, day 2, day 3 like that. Day 3, typically day 3. Day 3 and disappear by day 7, it will disappear. And it is mild, does not need a treatment. That is the physiological jaundice. Okay, carry on.
Okay, so it is a diagnosis of inclusion. Means that we must rule out first other causes, and then we can diagnose the physiological jaundice, and no treatment is required. But the baby should be observed closely if there's a sign of worsening jaundice. Usually the duration must be less than 2 weeks for term and 3 weeks for preterm baby. Next. Next slide. Okay. So for the pathological jaundice, it's a jaundice on first day of life or at 2 weeks age. Usually pathologic, and we can be divided into early jaundice, which is start on the first day of life, and prolonged pathological jaundice, which is more than 14 days in term or more than 21 days in preterm. Usually the baby will presented with clay or white colored stool.
Why clay or white colored stool? Can you tell us why?
Hepatosplenomegaly may present and as well as anemia. Third one is a deep jaundice, in which and usually the bilirubin level will high, contributed hyperbilirubinemia. Pardon, Doctor? Pardon, Doctor?
Syakira,
Hello?
the doctor was asking
Doctor,
why does the stool become clay color? What pale colored stool? Why? How does
why pale colored stool?
Yeah, anyone can answer? Shahira does not know the answer. The question is open.
Signs of obstructive jaundice.
Obstructive.
Because there's no stercobilinogen.
No stercobilinogen, yes. Yeah, because stercobilinogen or stercobilin is the one responsible for the color of the stool, the one responsible for the brown color. If the stercobilin is not there, so the stool will be white. Okay. Thanks. Continue.
Okay. For the this is the differences between the physiological and pathological jaundice. So you can see the difference here. For the physiological, usually onset after 24 hours of life. And then for the pathological, within 24 hours. And usually the total bilirubin for physiological rise less than 85 micromole per liter, and pathological rise more than 85 micromole per liter. And then for the physiological, maximum intensity is 4 by 4 to 50 in term and 7 day in preterm. And then usually for the pathological, jaundice persists after 2 weeks in term or 3 weeks in preterm unit. And the total bilirubin for the physiological jaundice is less than 257, pathological is more than 257. And for the physiological jaundice, clinically not detectable after 2 weeks in term and 3 weeks in preterm. But for the pathological, we have clear colored stool, dark colored urine, and SRF conjugated bilirubin more than 25 micromole per liter. Okay, so this one is for the pathological jaundice. We can divide it into the unconjugated and conjugated. For the unconjugated, just now is hemolytic and non-hemolytic causes, and for the conjugated, we can be divided into obstructive, infectious, metabolic, toxic, and autoimmune cause. Okay, this one is for the unconjugated pathologic jaundice cause. For the hemolytic, we have resist isoimmunization, ABO incompatibility, red blood cell enzyme deficiency, red blood cell membrane defect, hemoglobinopathy, autoimmune hemoglobin, hemolytic uremic syndrome, Wilson disease, and also throat infection. And for the non-hemolytic, we have physiological jaundice.
Again, Shahira, I will interrupt you again. Here, your topic is neonatal jaundice. So you are mentioning Wilson disease and hemolytic uremic syndrome. We don't see in the neonatal period. We don't see them. Yeah, hemolytic uremic syndrome, it is acquired condition. It is infection. Who will tell me by which organism? Which organism can cause hemolytic uremic syndrome? Open question.
E. coli.
E. coli. Which type of E. coli?
O157H7.
Yes.
O157H7 strain.
Very good. O157H7 strain. This belongs to which enterocoli?
Enterohemorrhagic.
Enterohemorrhagic. Very good. And what is the source for hemolytic uremic syndrome? What is the food source?
From bowel.
The food source, it is acquired condition. Enterohemorrhagic E. coli attacks the bowel, yes. From where? What is the food source? The common food source?
Not sure, Prof.
Anyone knows? The common food which cause hemolytic uremic syndrome via enterohemorrhagic E. coli?
Is it meat, Prof?
Yes, meat. Which meat? Which meat?
Red meat.
Yes, which red meat?
Which red meat? I'm not sure, Prof.
It is hamburger. Hamburger.
Hamburger. Oh.
Hamburger. Huh? So we don't see in the neonate. So like this one, you need Wilson disease, you need to remove. Hemolytic uremic syndrome, you need to remove. Autoimmune hemolytic anemia also you need to remove. Yeah, and hemoglobinopathies, like I said, thalassemia and sickle cell anemia, we don't expect them to present in the neonatal period. Enzyme deficiency, yes. RBC membrane defect, yes. Hematoma, yes. Yes, polycythemia, yes. Okay, go to the others. Yes, Shahira, can continue.
Okay, so next slide. Okay, this one is the comparison for the breastfeeding breast milk jaundice. So for the breastfeeding jaundice, it's usually in first week after birth in the breastfeed babies, and pathophysiology usually caused by the insufficient breast milk intake, which can lead to the lack of calories and inadequate bowel movement to remove the bilirubin from the body. So this will increase the enterohepatic circulation and increase the reabsorption of bilirubin from the intestine. So usually can be treated frequent breastfeeding and lactation support. For the breast milk jaundice, usually occurs within 2 weeks after birth and lasts for 4 to 13 weeks. Usually caused by the increased beta glucuronidase in breast milk and lead to the increased deconjugation and reabsorption of bilirubin. So make the physiologic jaundice persistent. So the treatment, we need to interrupt the breastfeeding of the baby for 1 to 2 days and resume back the breastfeeding. And if required, we need to do phototherapy to the baby.
Stop here, Shahira. First, breast milk jaundice, the mechanism it is not known yet. One beta glucuronidase is a theory. It is the circulation of beta glucuronidase. It is a theory. There is another theory also. One substance in breast milk called pregnan 3 alpha 20 beta diol. That one also inhibit conjugation. And there is another theory of polyunsaturated fatty acids. Polyunsaturated fatty acids in breast milk inhibit conjugation. So that's why unconjugated bilirubin increase. For the treatment, interrupt breastfeeding, we don't encourage that, please. We always encourage breastfeeding. That one, they mentioned that you may do it as diagnostic test. As a diagnostic test, you stop breastfeeding for 1 to 2 days as diagnostic. But if you have good experience and you can exclude other pathological causes, don't interrupt the breastfeeding. Don't interrupt. We don't like to interrupt breastfeeding. You know, the problems of the formula. We always need to support breastfeeding. Okay.
Okay. Next slide. So this one is still for the conjugated pathologic jaundice causes. Can be divided into obstructive, metabolic, autoimmune, infectious, and toxic. For the obstructive, we have the allergen syndrome, biliary atresia, and then cholelithiasis, and as well as tumor or neoplasm. And then for the metabolic, we have alpha-1 antitrypsin deficiency, galactosemia, tyrosinemia, and cystic fibrosis. And then for the autoimmune, we have autoimmune hepatitis as well as meningitis. For the infection, we can have viral hepatitis, bacterial sepsis, UTI, urinary tract infection, and also leptospirosis. For the toxic, it can be from the total parental nutrition and also can be drug induced.
So again, you are putting some causes which we don't put them to happen in the neonate. Okay, I will ask open question. Anyone knows what is Alagille syndrome? Alagille syndrome.
Sorry, Prof. I don't know.
Yes, tell me.
It's actually a genetic disorder which can cause liver damage. And then the cause usually by the bile duct abnormalities.
Okay, very good. Okay. So what they have outside of the liver, what they have?
Pardon?
Outside the liver, what other abnormalities they have? What dysmorphic features they have? Do they have problem in the vertebrae? Do they have problem in the eyes, in the kidney?
Pulmonary artery stenosis.
Yeah, very good. So they have pulmonary artery stenosis in the heart. They have pulmonary artery stenosis. Okay. What they have in the kidney?
For the kidney, I'm not sure, Prof. I remember the heart disease, and also for the ocular is actually the posterior embryotoxon.
Very good. Posterior embryotoxon. Okay. What else? What they have in the vertebra? They have characteristic vertebra.
Vertebra.
Butterfly vertebrae.
Very
Yes.
good. Butterfly. Butterfly. If you go to Google, search for butterfly vertebra, you will see. The vertebra is like butterfly. The vertebra is like butterfly. So what is the genetic defect in Alagille syndrome? What is the genetic defect?
Chromosome 20 deletion, Prof.
Yes, there is micro deletion. It is micro deletion. It is different when you say deletion or micro deletion. Micro deletion, same like which syndrome has congenital heart disease and hypocalcemia?
Or DiGeorge syndrome.
George.
DiGeorge.
Catch-22.
Yes, catch-22. It has micro deletion also. So DiGeorge has micro deletion. Alagille has micro deletion. DiGeorge micro deletion 22. Alagille micro deletion 20. How to diagnose micro deletion? What is the test for micro deletion?
Fish, Prof.
The fish.
Fish, yes. So go take fish for your lunch today. So you remember DiGeorge and Alagille.
Prof, may I ask, what's the difference between deletion and microdeletion, Prof?
It is in the base pairs. In the base pairs, the size. I'm not sure how long is the deletion space to say micro, but when you say micro deletion means it is small area, small segment. Deletion is larger segment.
Okay, thank you, Prof.
Okay, welcome. Okay, carry on, Shahira.
So this is the risk factor for the severe neonatal jaundice. We have a premature baby, low birth weight, and jaundice in the first 24 hours of life, and mother with blood group O or rhesus negative. This is feeding deficiency, rapid rise of total serum bilirubin, sepsis, lactation failure, kepada hematoma or bruises, and family history of severe neonatal jaundice in siblings. Go to the characteristics, which is the complication of the unconjugated bilirubin that deposited in the vasa ganglia. So we know that unconjugated bilirubin can cause blood-brain barrier. Usually the baby can be manifested at the early stage, lethargy, hypotonia, irritability, poor motor response, poor feeding, and also high-pitched cry. And for the late presentation, the baby may have bulging fontanelle, office tetanus, pulmonary hemorrhage, fever, hypertonicity, and as well as seizure. So if we do...
Okay, I will ask one question here. It is open question to all. Any abnormal movement you can see when you have kernicterus? Other than the seizures?
Chorioathetosis.
Chorioathetosis, very good. What else? Any other abnormal movement? Other than chorioathetosis? If the baby is moving
Dystonia.
like this. What is it?
Dystonia.
Dystonia. So tell me what the definition of dystonia?
Dystonia is
Involuntary,
involuntary,
purposeless, slow, sustained, twisting. Involuntary, purposeless, slow, sustained, twisting. This is dystonia. What is the definition of chorea?
Involuntary, purposeless, rapid,
Yes.
flowing, and irregular.
Irregular, very good. Involuntary, purposeless, rapid, flowing, irregular movement. Very good. Very good. Okay, carry on, Shahira.
Okay, so next. Okay, so this is clinical pictures. Clinicals, we can have acute bilirubin encephalopathy and also chronic bilirubin encephalopathy is other name of the clinicals. So for the acute bilirubin encephalopathy, we have phase 1, which is the first 1 to 2 days, in which the baby may have poor sucking, stupor, hypotonia, and seizure. And for the phase 2, usually occur in the middle of the first week, in which the baby may have hypotonia of the extensor muscle, opisthottomus, retrocolis, and we have fever. And phase 3, after the first week, the baby may present with the hypotonia. For the chronic bilirubin encephalopathy, usually during the first year, baby may have hypotonia, active deep tendon reflexes, and also obligatoric neck reflexes and delayed motor skill. And after first year, they may have abnormal movement disorder, which is the choreoathetosis, balancement, tremor, and also presented with the upward gaze and sensory neural hearing loss. Okay, this one is the bilirubin-induced neurologic dysfunction BIND score, used to So now we move to the approach to the neonatal jaundice. So first we have the history, in which we must know the age of the onset of the jaundice to look whether there's a physiological or pathological jaundice. And then next, is it the baby term or preterm baby? And then presence of acute bilirubin encephalopathy symptoms that we have discussed before. And we also must ask the birth history. Is it a small risk factor for the jaundice, which is small for gestational age? We must ask the maternal blood type and disease status. Is there any maternal infection, traumatic delivery, or perinatal asphyxia? And as well, we must ask the family history. Any sibling with neonatal jaundice, clinic stress, B deficiency. Okay, so and then this one is the presentation for the unconjugated hyperbilirubinemia and conjugated hyperbilirubinemia. So usually for the patient with the unconjugated hyperbilirubinemia, it may have feeding pattern. We must ask the feeding pattern, type and amount of milk intake, presence of vomiting and irritability, feeding intolerance, family history of blood group and measles, GSVD and hemoglobinopathy. We must ask the drug history. And then small for gestational age and also post-trauma. For the conjugated hyperbilirubinemia, presentation is dark urine color and black stool. Jaundice more than 2 weeks, maternal and parental history, and as well as family history for jaundice, liver disease or other metabolic disorder. Okay, next we move to the physical examination. So for the general, we must look for the gestational weight, if there's any sign of sepsis, and also the hydration status of the baby. And then we look at the face, if there's dysmorphic, clitora, and for the eyes, we look if there's any conjunctival pallor,
So
cataract.
if the patient has a beaked nose and large ears and micrognathia, what would you think in? Beaked nose, large ears, and micrognathia. What syndrome?
Is it Noonan because of the micrognathia? Is it
No, it is
Noonan
not
syndrome?
Noonan.
Because micrognathia.
It's not Noonan. It is one syndrome having jaundice. One syndrome causing neonatal jaundice. Just now we're talking about it.
Alagille
Agile.
syndrome.
Yes, Alagille syndrome.
Alagille syndrome.
Yes, Alagille. So beaked nose, they call it bulbous. Bulbous nose. B-U-L-B-O-U-S. Bulbous nose, micrognathia, and large ears. Alagille. Okay? Carry on. Continue, Shahira.
Okay. So for the this one is the visual assessment for the jaundice. We use the Kramer's rule, in which we look at the area of the body with yellowish discoloration, and then there's a range of bilirubin. So we can perform it by blanching the skin with a slight finger pressure. However, usually in the baby of dark skin, may be difficult to observe. But this assessment is unreliable when on phototherapy. Okay, this one is the sign of the bilirubin encephalopathy. The baby may have a hypotonia or hypertonia, seizure, tetanus is like the picture that's shown, retrocolis, and as well as high pitch cry.
So the photo you are showing us what posture it has. So you put one photo here, having certain posture. So what is the posture in the photo? Posture of the baby in the photo?
The tetanus posture.
Tetanus, very good. Yeah, so the baby has tetanus. We can see it. Arching of the back. Arching of the back. Okay, very good. Okay. Carry on.
Okay, so for the investigation, we must do the total and direct bilirubin level, and then we must do the blood group analysis for mother and baby. We must do the full blood count to look for the hematocrit, if there's any polycythemia, and then full blood film if we suspect spherocytosis, and then this is PD assay, home test, then we must do a septic workup, liver function test.
Okay, I will interrupt you, Shahira. I will ask one question. So you said you want to look for full blood film, to look for spherocytosis. Yes, that's correct. But not only hereditary spherocytosis can cause spherocytes. Other conditions also can cause spherocytes in blood film. Who will tell me what are the other conditions which can cause spherocytes in blood film? Any other conditions can cause spherocytes?
Hemolytic uremic syndrome?
Yes, what? Hemolytic uremic syndrome. No.
No.
Thalassemia?
No.
How about hemolytic uremic syndrome?
No.
Hemolytic anemia?
Spherocytes. Condition, you see spherocytes. You look at the blood film, you see spherocytes. So number one, hereditary spherocytosis. Number two,
malarial infection.
No, not malaria.
Autoimmune
hemolytic anemia?
Yes, yes. Autoimmune hemolytic anemia can, yes. Autoimmune hemolytic anemia can cause spherocytosis. Okay, what else? ABO compatibility. ABO compatibility can cause spherocytes. Wilson disease also can cause spherocytes. So Wilson disease, autoimmune hemolytic anemia, ABO compatibility, thermal injury, and clostridial sepsis. These are the causes of spherocytes.
Sorry,
Prof.
Prof.
What's the last point, Prof?
Clostridium sepsis.
Clostridium sepsis. Oh.
Yes. And thermal injury.
Yeah. Okay, thank you, Prof. Clostridium sepsis.
So the common ones in the neonate, when you see spherocytis, you think either hereditary spherocytosis or ABO compatibility. These are the two conditions which we see in the neonate. Any test, we differentiate between them. Simple test. Last time in the medical school, we did it in the physiology.
Combs test.
No, not Combs test. Yeah, so this test differentiates between ABO compatibility and hereditary spherocytosis. It is primitive test.
Full rapid
Fragility test, Prof.
What is it?
Osmotic fragility test.
Very good. Yeah, it's osmotic fragility test. Osmotic fragility test. Very good. Okay, carry on, Shahira.
Okay, so next we go to the management. We have management, we have screening and prevention. So first we must do screening for the mothers and fathers blood group, and also screen for the TCK deficiency, hypothyroid screening, look for TSH and free T4 level, and also immune error metabolism screening. For the prevention, NTD immunoglobulin to reduce negative mother, but I don't know how. And then encourage mother to breastfeed their healthy term baby and near term newborn about 8 to 12 times per day. And then for the indication for the referral to hospital, first is jaundice within 24 hours of life. Then jaundice below the umbilicus, which indicate 200 to 200 micromole per liter. Jaundice extend to the sole of feet, in which need urgent referral. And also this baby may need exchange transfusion as treatment. And then there's the family history of significant hemolytic disease. The infant is unwell with jaundice and also prolonged jaundice of more than 14 days. Okay, so this one is the treatment for the if there's unconjugated jaundice. So we have phototherapy, we have exchange transfusion. For the pharmacotherapy, we have IV immunoglobulin and also female monitor. For the conjugated, if there's caused by the military ataxia, we can give glucoside procedure. Galactosemia, give lactose-free formula. And then we need to treat underlying infection. If there's a hypothyroid, we give thyroxine, and also there's a surgical incision of cysts. Okay, so this one is the capital assessment monitoring. So you can look at that. This one is the explanation for the phototherapy. So indication for the early phototherapy, if there's bilirubin level rise faster than 0.5 milligram, persistent or severe metabolic ulcerative acidosis, sepsis, or 6 very low birth weight infant. So the mechanism of action in phototherapy, in which there is a skin exposure to light that causes the geometric photoisomerization and bilirubin photoisolation, which allow the albumin binding and diffuse. But it is not useful in neonate with elevated conjugated bilirubin. Next. Okay, and then the technique done in the phototherapy, usually we expose the maximum surface area we must apply the iPad and the gonadal protection to the baby. We must
Shahira,
monitor the
I will
yes.
stop you, Shahira. Go back to the previous slide. Go back to the previous slide. You said not useful in the neonates with elevated conjugated bilirubin. So there will be one complication. If we use phototherapy for conjugated bilirubin, there will be one complication. Anyone knows the complication? What complication happened to the baby?
Like burn, Prof, because hot.
No,
Like
I
skin
want
irritation.
something specific for conjugated bilirubin. Something specific for
Skin
conjugated
bronze.
bilirubin.
The skin will be turned bronze, discoloration.
Yes, very good. They call it bronze baby syndrome. Bronze baby syndrome. Very good. Carry on, Shahira.
Okay. So usually we okay, and then monitor the hydration status, which is the urine output. And then for the effective phototherapy, we use the blue light range. And then the distance of the light source to the baby is not exceeding 30 to 50 centimeter. Okay, next. Okay, the technique. This one technique done in phototherapy. So the light source usually we use the light band, spotlight, fiber optic blanket, and LED. Color of the light usually white, blue, or green. And then the wavelength must be 420 to 500 nanometer irradiance. Okay. And then position must be 15 to 20 centimeter above the infant. Must expose the largest surface area. Okay, so for the precaution, we must ensure the pattern airway of the baby, and then maintain the constant body temperature using incubator and neutral thermal environment. We must assess the temperature every 4 to 8 hours. Maintain the fluid balance, increase intake and minimize loss of fluid. We must cover the eyes and genitalia of the baby, and don't forget to check the skin integrity. We must do frequent diaper changes, water bath, not apply any lotion or oils on the skin, and position of the baby must well positioned to avoid skin irritation. Okay, this one is the complication of the phototherapy. The baby might have dehydration because there's increased water loss, and baby may have loose stool, and baby may have irritability or lethargy, skin rashes, overheating, retinal injury, adverse effect on cell growth, oxidase essential fatty acid, decreased vitamin and calcium in premature baby, and that one, tannic or bronze baby syndrome that discussed before. Okay, next treatment is the exchange transfusion. The indication for the exchange transfusion, if there's intensive therapy fail, and if the baby have severe hyperbilirubinemia, in which they may have risk of cardiac arrest. And then the type of blood and volume used in the exchange transfusion is the fresh whole blood, and then volume that is total infant total blood volume. Usually the complication that may arise from this kind of treatment is thrombocytopenia, portal vein thrombosis, hepatitis enterocolitis, cardiac arrhythmia, hypoglycemia, hypomagnesemia, and glycemia, and as well as respiratory and metabolic acidosis, and also infection. Okay, this one is the treatment for direct hyperbilirubinemia. So we must treat the underlying causes. So if the patient have cholestasis, we must stop the TPN and cystic cholestasis. We must stop the total parenteral nutrition. And then we must follow the TPN consensus protocol. However, the phenylorbital use is controversial, and if the baby have respiratory atresia, we must do cancer procedure with or without liver transplant. And then the hormone antitrypsin, we must do a liver transplant, and then the diagnosis with surgical removal, and galactosemia with the lactose milk, and supportive care if there's no treatment possible. That's all.
Okay, thank you, Shahira. Thank you. Any questions to Shahira? Anyone wants to ask Shahira any question?
I have a question. In pediatric protocol, there's a table by NICE guideline and also table by the American Association of Pediatric indicating the level of bilirubin and then when to start the either the phototherapy or the exchange transfusion. My question would be that at the leftmost corner of the table, the first column has the hours of life. Can you explain about how to use the hours of life in relation to the table? Because I'm confused with the how to read the table. Thank you.
The table in pediatric protocol.
In the pediatric protocol, the table where there's a level of bilirubin correlating with the when to the use of phototherapy and also the exchange transfusion. There's the table. First one is by AAP guideline, and the second one will be the by NICE guideline. My question will be that what is meant by the first column, the hours of life, the 6, 12, 24, 48.
Okay, I will let me open the pediatric protocol and see. Okay, let me open my computer. Pediatric protocol. Okay, I will download it from the internet. I couldn't find it in my computer, so let me download it.
Prof,
Is it third
I
edition or
can
fourth edition?
I can share the screen if you want, Prof.
Okay, please. Yes.
This one, Prof.
I can't see a clan.
Can you pin the one that I'm presenting, Prof? Yang lain nampak ke?
I think.
Student?
Yeah. Okay. Okay. Let me bring the phone closer because my phone is small. So your question is the first column, is it?
Yeah. I mean, like, we have the 6, 12 hours of life, 24. I mean, like, what if the value is in between the numbers? Like, let's say we have 8 hours of life or 9 hours of life.
Yeah. I understand. Yeah, it is all just estimation. It is all estimation. So see the child. In fact, to be accurate, 100%, you don't use this table. To be accurate, 100%, use the graph.
Graph.
Yes, for the graph, you will find at every hour of age, you will find certain level. You will see x-axis for the age and y-axis for the bilirubin level.
Okay, Prof. Yeah. Do we need to remember the graph, Prof?
No, we don't need. We at any time, always when we manage the babies, we look for the graph. Everywhere in every hospital you go, you do your housemanship. The ward will they have the graph. So you just ask for the graph, take the age of the baby, plot on the x-axis, and go in the y-axis, see the bilirubin level. Then see where it lies. Is it below the level of phototherapy or above the level of phototherapy?
Okay, Prof.
Okay.
Thank you, Prof.
Welcome. Any other question to Shahira?
Assalamualaikum. My name is Muhammad Jazli. I would like to ask regarding the interrupted breastfeeding. So it's mainly for diagnosis purposes instead of treatment, is it?
Yes.
Oh.
Yeah, it is for diagnosis only because breast milk jaundice is not dangerous. It's not dangerous. It does not cause kernicterus. Despite it can go high, but does not cause kernicterus.
We see if there's any improvement or not. If not, we have to assume other differential.
Yes.
Okay. Right. Thank you, Prof.
Welcome. Okay, so we go to next presenter. Thanks, Shahira.
Okay, I will be the presenter.
Okay, Dua.
Can you see my slides?
Can.
Yes. So my topic will be on neonatal anemia. So the outline of my presentation will be defining what anemia is, going on to the pathology, and then history taking, physical examination, and then we'll go on to investigations and treatment. So this is the hemoglobin a graph of how we have in our red blood cell, we have hemoglobin and globin, right? So there's alpha chains and beta chains. Normally we have alpha chains and 2 beta chains, but for fetal hemoglobin, it's usually alpha and gamma chains that makes the hemoglobin F. After birth, they will start developing the beta chains, and there'll be reduction in the gamma chains, and then they'll move on to the normal adult hemoglobin, which is like A or B, you know.
Very nice.
So,
This graph is very nice.
There's
yes, carry on, Dua.
This is the normal hemoglobin values for term and premature entrance. So we'll start with full-term birth, which is the second column. And for at birth, the normal hemoglobin level will be 19.3. And then as you go on to like 0.5 months and 1 month, you can see that there's a decreasing trend. By 9 to 12 weeks, the hemoglobin level will be at its lowest. It's called another point in their life where the mean hemoglobin will be at around 12.2, and then after those 9 to 12 weeks, then at 4 to 6 months, then we will start to see an increasing trend. The same thing in immature, but there will be the values will be less than full term. So at birth, their hemoglobin values will be less, and then their decreasing trend will be lower, basically. So instead of 11.2, it will be 9.4 at the nadir point, and then to 6 months, then it will start to increase back up again. This is important when we will come to explain about physiological anemia. So the definition of anemia is defined as hematocrit or hemoglobin concentration going to more than 2 standard deviations below the mean of age. Or we can define it as central venous hemoglobin of less than 13, capillary hemoglobin of less than 14.5, or hematocrit less than 45% in patients. So the pathophysiology.
Yes. Dua, I want to ask you one question. Yeah, I don't know that before. Why central venous hemoglobin is different from capillary hemoglobin?
Because of the from how I understand it is that the capillary hemoglobin will more deposition of red blood cells.
More like deposition of the blood cells.
Yeah, we can get more red blood cells from the capillaries rather than the central venous.
Okay.
So the readings will be higher.
Okay, good. Yeah. Okay, carry on.
So the pathophysiology, we will be talking about 4, which is physiological anemia, hemorrhagic anemia, hemolytic anemia, and hypoplastic. So starting with physiological, this is normal. It is the most common cause of anemia in young infants. It usually occurs about 6 to 9 weeks of age, which is what we showed in the graph in the table earlier. This is usually caused because there is a decrease in erythropoiesis after birth. This is a result of the decrease in erythropoiesis is because there will be increased tissue oxygenation, and therefore there will be a reduced production of erythropoietin because of a negative cycle that the tissue super perfused, so there'll be less production of erythropoietin. In healthy infants, hemoglobin levels are high at birth, usually more than 14, and then there'll be a rapid decline, nadir approximately at 11 at 6 to 9 weeks of life. This is usually called physiological nadir. How to differentiate this physiological from pathological anemia is that the anemia, the hemoglobin in pathological anemia, hemoglobin than 13.5 within a month of life, which basically means that before the nadir point, there will be a reduction of less than 13 0.5 like the reading. And then, or the anemia will have a lower hemoglobin level that is seen at that age. With physiological anemia, example will be less than 9, or there will be signs of hemolysis such as jaundice, all the other signs of jaundice. Or there can be symptoms of anemia such as irritability or poor feeding. Usually for physiological jaundice, it does not require physiological anemia, it does not require extensive evaluation or treatment. Everybody clear on this before we move on? Okay, I'm going to take that.
Sorry, what's Nadir?
It's a physiological decrease in hemoglobin. It's you can call it physiological anemia or nadir.
Oh, physiological anemia or nadir. Oh, okay.
So for hemorrhagic anemia, it's because of blood loss. So in neonates, the absolute blood volume is low. In preterm babies, it's usually 90 to 105 milligrams per kg. And in term babies, it's usually 78 to 86 milligrams per kg. So in this case, any acute blood loss as little as 15 milliliters may result in anemia. So an infant with chronic loss, actually blood loss, can compensate physiologically better and be more stable than an infant with acute blood loss. And that the acute blood loss here is as little as 15 to 20 milliliters of blood. So this can be caused by three main points that we will be going on to explain. Loss, blood loss, and postpartum blood loss. But it's important to remember that diagnostic factors such as amniocentesis or chronic villus sampling, umbilical cord blood sampling can also lead to this blood loss. So we will start by postpartum. So the causes for this blood loss will be like fetal maternal hemorrhage. This usually occurs spontaneously or can result as a cause of from maternal trauma, amniocentesis, external version tumors arising in the placenta. It usually affects 50% of pregnancies, but of blood loss is usually very low, so it's not enough to cause hemorrhagic anemia because usually the blood loss is a milliliters. However, if we have a massive loss of more than 30 milliliters, that can cause fetal to maternal hemorrhage and then cause hemorrhagic anemia, and that usually occurs in about 3 to 1,000 pregnancies. There's also twin transfusion as a cause of antepartum hemorrhage. It is usually due to unequal sharing of blood supply between twins. Affects 30 monozygotic monocryonic twins. So you'll have a donor and a recipient in this case. Sorry, recipient, it's spelled weird. In twin-to-twin transfusion, if there is a significant transfer of blood from one twin to the other, the donor twin will become anemic and may suffer from features of heart failure, and the recipient twin will be cythemic, and then they'll have hyperviscosity due to the transfer. There are also causes of malformations and placental abnormalities. So for cord malformations, we will focus on two, the vasa previa and the velamentous insertion. So in vasa previa, it's the first picture whereby the fetal blood vessels within the membranes are located below or the internal os. So there becomes pressure from the fetal head. There can actually be bleeding of the internal os. Okay, and for the velamentous insertion, as you can see that there's no in the second picture, there's three. The first one is normal, where you can see that the umbilical cord is coming out of the placenta and into the baby, and then in the second picture, you can see that the cord is actually coming out a little bit away from the placenta. So there'll be exposed blood vessels, and it becomes worse when it's with vasa previa as well. whereby you can see that the exposed blood vessels run from the placenta to under the baby's head and then go on to the baby. And over there, when there's pressure from the baby's head, then the bleeding can be bigger. Moving on to placental abnormalities. So in placental abnormalities, the ones that we want to focus on is placenta previa and abruptio placentae. So in abruptio placentae, obviously there'll be like a lot of bleeding. In previa, there can be levels, such as if there's low implantation, then there can be little bleeding. Partial previa, the bleeding will be a little bit more, and in total placenta previa, we'll have massive bleeding in some cases. So this is for antepartum. Any more questions? Any questions on antepartum before we go to intrapartum?
I have one question. For
Yeah.
the antepartum, for the twin transmission just now,
yeah,
the recipient will have polycythemia and also hyperviscosity, right? Will that also lead to stroke after a while?
I did not read about strokes, but I think the idea of it is to manage the recipient before hyperviscosity can lead to a stroke.
Oh, okay, thank you.
When you have polycythemia, it is always risk factor. It is one of the virtuous triad. Yes, polycythemia always risk factor for stroke. It is one of the causes of stroke in the infants.
Okay, thank you, doctor.
Okay, welcome.
Can you hear me?
Yes.
In what condition does the fetal to maternal hemorrhage occur?
Me?
In what condition does the fetal to maternal hemorrhage occur?
Oh, it usually occurs spontaneously, or if there is maternal trauma, or let's say the baby is not lying properly, external version, or if there's a tumor. But the spontaneous occurrence, it usually affects 50% of pregnancies, so it's actually pretty common. But in those 50%, the amount is very minimal, so it doesn't cause hemorrhagic anemia in the baby. When there is massive loss, which is more than 13 millimeters, it occurs in about 1,000 pregnancies because of those maternal trauma and amniocentesis and such.
So the
Very good,
hemorrhage,
yes,
occurs origin for the mother, and then later it affects the fetal circulation. Is it?
I'm sorry, can you raise your voice?
So the hemorrhage starts from the mother, and then later it affects the fetal circulation. Is it?
The hemorrhage will occur between the mother and the fetal circulation. It's not like the mom is bleeding and then the fetus will have anemia.
Okay.
It is in the void junction between, above the placenta. So the void of where the maternal blood comes and the fetal blood is there. That's why they call it feto-maternal.
Okay, thank you. Thank you.
Okay, so we'll move on to intrapartum. So partum hemorrhage will usually happen in precipitous delivery, that is a rapid and spontaneous delivery, which causes due to umbilical cord tearing. So think of this as almost an aggressive delivery. Or it can happen because of obstetric accidents, such as incision of placenta during cesarean delivery or any other birth trauma that can happen, let's say during instrumentation. There can also be coagulopathy, both in the mother and the child side, that can cause hemorrhage, and in this point we have to focus on subgluteal bleeds, which can wrap into the soft tissue, and they will like gather there or sequester there enough sufficient blood volume to cause anemia, hypertension, and shock and death. So obstetric trauma, because these are newborn, have to think of the subgluteal bleeds because because sutures are not fused yet. So there can actually be a large volume that is hiding under there. So in trauma, it can cause occult visceral or intracranial hemorrhage. So neonates with intracranial hemorrhage can lose sufficient blood into their intracranial vaults and cause anemia and sometimes hemodynamic compromise such as hypertension, shock, eventually leading to death. Because unlike older children who have a lower head-to-body ratio, and their intracranial hemorrhage is limited because in volume, because they have fused cranial sutures, and these fused sutures will not allow to expand. So instead, there will be a buildup of intracranial pressure, and that may be able to stop the bleeding if it's so massive. And then they will show signs of increased intracranial pressure. While in neonates, because sutures are not fused, there will be less signs of increased intracranial pressure because there can be expansion into that intracranial space.
Can I ask?
Yeah.
I don't really understand why the mother with obliquitis can cause neonatal anemia.
Because this is intrapartum, so this is at a point where the mother is giving birth. So if there comes a rapid and it's basically aggressive delivery, then there can be umbilical cord tear. So if the mother starts bleeding and there's umbilical cord tearing, then the child can bleed as well.
So it's due to the stress to the umbilical cord and the mother. Okay.
So in postpartum hemorrhage, it's usually an enclosed hemorrhage. If there is an enclosed, sorry, it's not usually. If there is an enclosed hemorrhage, may suggest trauma or severe perinatal stress, such as caput secundum or cephalohematoma or intravenous hemorrhage and visceral hemorrhage. There can also be caused by defects in hemostasis, congenital coagulation factor deficiency, consumption coagulopathy, such as disseminated intravascular coagulation, or sepsis, or there can be vitamin K deficiency, in which case failure to give vitamin K, that's bleeding at 3 to 4 days of age. There can be thrombocytopenia, such as immune or congenital, and blood loss due to blood draws. Remember that the neonates or the babies have smaller blood volumes. So if we draw a lot of blood from them, then we can actually induce anemia.
Okay, Dua, I will interrupt you. I will ask one question, open question. So you mentioned the vitamin K deficiency, which is hemorrhagic disease of the newborn, and you mentioned DIC. How to differentiate by investigations? What is the difference in the blood investigations between DIC and vitamin K deficiency? Open question.
Assalamualaikum, Prof. I think if vitamin K deficiency is only affect the coagulation profile. However, with DIC, it will affect both coagulation profile as well as the platelet.
Very good. Correct answer. Yes. This is the answer. This is the answer. Yes. So DIC, we will have thrombocytopenia, raised PT, and raised APTT. While vitamin K deficiency only raised PT and ABTT with normal platelet. Thanks. Okay, carry on. Dua.
So this is just a picture of the hemorrhage. So we're going to move on to hemolytic anemia. So this is the usual blood groups. We have AB, and O. This is just a revision. In group A, the antibodies in plasma will be anti-B. In group B, antibodies will be anti-A. AB will have no antibodies. Group O will have antibodies for both because of the antigens that they have in their blood. So in hemolytic anemia, there can three causes: immune hemolysis, non-hemolysis, and erythrocyte defects. In immune hemolysis, there can be ABO or recessive incompatibilities. It can be autoimmune or fetal maternal hemorrhage. In non-immune, there can be torch infections or reduced hemolysis. Erythrocyte defects such as G6PD, thalassemia, hereditary spherocytosis, and sickle cell, which may clear. So we will move on to hypoplastic causes. Hypoplastic causes can be congenital or acquired. In congenital, we can have Fanconi anemia and diamond blackfan. These both affect bone marrow, whereby there will be less production red blood cells within the bone marrow. In one of them, I think it's diamond blackfan syndrome, there will be less reticulocytes within the peripheral blood film as well. For congenital, we can also consider congenital leukemia or sideroblastic anemia. In acquired, we have to consider infections with parvovirus or rubella, nutritional deficiencies such as iron, copper, folate, vitamin B12, B6, C, and E. We also have to consider aplastic anemia, and it can also be caused by anemia of prematurity.
Okay, Dua, I will stop you. I will ask one question. Okay, I will ask you. Can you tell us what are the skeletal features of Fanconi anemia and Diamond Blackfan syndrome?
What are the
skeletal features? Skeletal abnormalities.
I'm not sure about that. I'm sorry.
Okay, so open question. Anyone knows skeletal abnormalities in Diamond Blackfan syndrome or Fanconi anemia? Open question.
Fanconi will have short stature.
Okay. Short stature, yes. What about limb abnormalities? Any limb abnormalities in Fanconi anemia?
Loss of thumb.
Okay, so they may have absent thumb. Very good. They may have absent thumb or absent radius. Absent thumb or absent radius. What about Diamond Blackfan?
Not sure that
the same thing. Also, they may have thumb. Yes, yes. Yes, please. Triphalangeal thumb. So Diamond Blackfan also may have thumb abnormalities. Triphalangeal thumb, or also they may have absent thumb. So again, Diamond Blackfan, common to have thumb abnormalities, Fanconi, thumb abnormalities, and absent radius. There is one common question if you are interested in pediatrics and you are going to sit for Royal College exams. What are the causes of absent radius? They are famous for causes of absent radius. One of them is Fanconi anemia. 3 other conditions. So I give you a clue. One of the conditions is autosomal dominant condition associated with ASD. Associated with ASD.
Williams syndrome? Williams syndrome?
No, not Williams syndrome. Which syndrome is associated with ASD? Start with H, H-O.
Holt-Oram syndrome.
Very good. Holt-Oram. Holt-Oram syndrome. So Holt-Oram syndrome, they may have absent radius. So cause of absent radius include Fanconi anemia, Holt-Oram syndrome, and 2 more conditions. Pneumonics. The two other conditions are mnemonics. One from 7 alphabets and one from 3 alphabets. One starts with V, the other starts with T. Yes?
Thrombocytopenia absent radius.
Very good. Thrombocytopenia absent radius, TAR. They call it TAR. TAR syndrome. TAR syndrome. Thrombocytopenia absent radius. TAR syndrome. That's one. Very good. The other one start with V. VA. They may have tracheoesophageal fistula.
VACTERN.
They may have tracheoesophageal fistula. Bacterial. Very good. Bacterial. So these are the common causes of absent radius. Fanconi anemia, TAR syndrome, Holt-Oram syndrome, and bacterial syndrome. Okay, very good. Carry on.
Okay. So we will move on to diagnostic approach. So presentation, we have to always determine the following factors, which is the age at presentation, any associated clinical features, hemodynamic status of the infant, as well as if there is presence or absence of a compensatory reticulocytosis. And signs of anemia are similar, perinatal anemia are similar regardless of the cause, but they can vary with severity and rate of onset of the anemia. The major physiological impact of anemia increase in oxygen delivery to the tissues, and that will result in both compensatory responses and acute or chronic consequences that can include poor growth, decreased activity, and limited cardiovascular reserve. So we'll go on to each type of anemia, just hemorrhagic and hemolytic. Comparison of the first two, remember, both of them will present with pallor. Hemorrhagic presents at birth, can be a sudden onset, and it can be there is no jaundice and but there can be hemolytic. In hemolytic, there will be jaundice because of the unconjugated hyperbilirubinemia. In hemorrhagic, there can be cyanosis that is unrelieved by supplemental oxygen. There can be there will be poor perfusion or signs of hypovolemic. There can be decreased central venous pressure, normocytic, normochromic, RBC in this, and you will have to look for any others, any sources of bleeding, such as the bowel. In hemolytic, remember that there will be jaundice. They can also present with hepatosplenomegaly, failure to thrive because their blood is being hemolyzed. Symptoms such as leukemia, lethargy, sorry, confusion is repeated twice. They can also with seizures or connectoric encephalopathy because of the unconjugated hyperbilirubinemia, and there can be reticulocytosis. There will still, in hypoplastic presentation, pallor is still there. It's usually uncommon. There will be anemic symptoms. However, there will be no jaundice and no reticulocytosis. It can be an enlarged or can present with heart or renal failure. There is non-specific coryzal symptoms or generalized rash, illness, or arthropathy relating to a virus. The onset can be within 3 to 2 weeks, and it's not resolving by 3 to 6 months. There will be an increased requirement of supplemental oxygen, unlike hemorrhagic, unlike hemorrhagic, unrelieved by supplemental oxygen, and there can be poor weight gain as well. So others, such as twin-to-twin transfusion, they can present with growth failure in the anemic twin, often more than 20%. And in occult or internal hemorrhage, if there is intracranial hemorrhage, you would note that there will be a bulging anterior fontanelle and neurological signs such as altered status, apnea, or seizures. In vessel hemorrhage, there can most often the liver is damaged, and that would lead to an abdominal mass. In pulmonary hemorrhage, the radiographic pacification of a hemothorax with bloody tracheal sepsis may be obvious. So we move on to history. History, we want to focus on birth history, such as the three major parts that we covered, which is antenatal, intrapartum, and postpartum. In natal, you have to know if it's a single or pregnancy, was there any antepartum hemorrhage, and the mother's and this. In intrapartum, you want to know if it was a spontaneous vertex delivery or C-section. What is the gestational week of the baby? Was there any bleeding? Was there any placenta previa or placenta abruption? Or was there any instrumental delivery that can lead to birth trauma? Postpartum, you want to know if there was any bleeding tendencies, birth trauma, any head swelling, any exchange transfusion done. You also want to focus on their feeding history, such as type and the amount. You want to focus on their growth development to note if there's any failure to thrive. And you want to read into their family history, such as any thalassemia, any anemia in the family, the ethnicity of the family, and any hereditary blood disorder, such as or sickle cell. So for examinations and investigations, for physical exams, you can refer to the previous notes where we discussed the three different types of anemia. But generally, you want to know if the baby is active or not, if they're lethargic looking, or if there's any you want to know if they're pale, if they're jaundiced or cyanose. Is there any dysmorphism or bleeding tendencies? You want to note the hemodynamic status and the vital signs. You want to know if there's any signs of respiratory distress, any hepatosplenomegaly, any skin rash or bruising. So we move on to investigations. In investigations, you want to take a full blood count, including reticulocytes, a full blood film, typing and direct Coombs test, bilirubin, total and indirect, and you want to take the Betke test. I'm not sure if I'm pronouncing it right, but this test is basically looking for fetal red blood cells, mom's blood. So maternal blood, and you're looking for if you find both blood cells, then it can be signs of fetal maternal hemorrhage. You want to take coagulation study, hemoglobin electrophoresis, ultrasonogram for internal bleeding, such as of the head or the abdomen, and you want to take bone marrow aspiration if it's needed. So for the treatment of neonatal anemia, we'll divide it into three: prenatal, intranatal, and postnatal. Prenatal will be injections in rhesus-negative mothers. Fetal is very required. In intranatal, you delay the cord clamping so that the baby, the contractions of the cord can give the baby more blood, push more blood into the baby. In postnatal, you want to consider simple transfusions for symptomatic newborns, such as premature babies on oxygen. You can also exchange transfusion for severe hemolytic anemia. To treat the underlying cause by iron supplements or steroids. You want to obviously give nutritional supplements such as iron, folate, and vitamin E, and always give supportive therapy, which includes oxygen therapy. You limit venous sections and erythropoietin given in prematurity because of anemia of prematurity. References. And we're open for questions.
Okay. Any question to Dua?
Sorry, I would like to ask, I think maybe, I'm not sure whether I've mentioned previously or not, but what's definition of early or late delayed clamping, like the timing? Is it like 1 minute or?
I to answer this.
Again?
So for cord clamping, if it should not go up to 1 minute, because if I'm not mistaken, what I remember my ONG posting is that you're supposed to observe the cord for contractions.
Oh, so it's supposed if it's so what's the definition for early and late and delayed cord clamping?
I can't give you a time. So maybe if someone knows, they can help.
I see. Okay, but you mentioned previously that at least we have to wait at least 1 minute before we can decide to clamp lah, based on the one you said regarding the ONG.
No, not up to 1 minute, because if you wait too long, then it's actually counterproductive. If you wait too long, then there'll be blood flowing out of the fetus into the mom.
Mm-hmm. Okay. Prof tadi. Okay. Because I have a question.
For the apa nama black fan diamond syndrome just now, diamond black fan syndrome, the hypoplastic anemia, meaning that the patient must be on transfusion indefinitely, or I mean, is it like major thalassemia?
For diamond black fan?
Yeah.
Well, I'm not sure about that. I'm not sure about the treatment of diamond black fan.
All right.
Dua?
Yes.
Sorry for interruption. Just now I went to my daughter. Just now there was one question about delayed cord clamping, is it?
Yes. Dasri asked, what is the definition of delayed cord clamping?
So what was the answer?
I couldn't give an answer.
You didn't give the answer. Huh? Also, I don't know what is the exact time. Yeah. So we can go and find out. Anyone from the students knows the exact time?
Because I did search previously, but they don't. I did not manage to find like a definite answer. It's like some say that.
You can ask Dr. Sayyid Abdul Khaliq. Dr. Sayyid Abdul Khaliq has very good neonatal experience.
Oh.
Maybe you can get answer from him.
Okay. Thank you, Prof.
Okay.
Prof, Atlan also asked about treatment of diamond black fan, whether it will always be on transfusion.
Diamond black fan syndrome, they require transfusion. A few percentage of them, they are lucky. They have spontaneous resolution. And some of them respond to steroids. So you can try steroids, you counsel the parents and try steroids use. And then bone marrow transplant also is effective. If you have much sibling donor, bone marrow transplant also is effective in them.
Thank you, Prof.
Welcome.
Okay, thank you.
Thank you. Okay, any other question to Dua? If no other question, we go to the next presenter.
Okay, Assalamualaikum. Can you hear me?
Yes.
Okay. Wait. Can you see the slide?
Yes, I can see the slide.
Yes,
Can you
please.
turn off the sharing button?
How? Sini.
Just hide. Hide.
Hi. Oh, hi. Okay.
Hi.
Okay. Okay, Assalamualaikum warahmatullahi wabarakatuh. My name is Alia Shahira binti Syahrudin. So today I will present to you about neonatal thrombocytopenia. So first, by definition, thrombocytopenia means when the platelet count is less than 150 times to the power of 9 per liter. So it can be in neonates, it can be classified into mild, moderate, and severe. So for mild, it is 100 to 150. For moderate, 50 to 100, and severe is when the platelet count is less than 50,000. So basically, platelet is a non-nuclear cell, so it involved in the primary hemostasis.
1 minute, Shahira.
Yes, yes.
Because I cannot see the slides here. I'm seeing in my laptop. What I see is mild 50 to 150, and moderate 20 to 50, and severe less than 20.
That one. I think I have a mistake. Which one you see?
I see the definition first slide. So you said mild thrombocytopenia, platelet 50 to 150, moderate thrombocytopenia, platelet 20 to 50, severe thrombocytopenia, platelet less than 20.
Okay. For that, actually, for the severity, I just correct it just now because the original one, I think it's for children in general, not for neonates.
I see. Which references did you use?
For this one. For
Yes,
the
for
one
this one and the new
that
one.
you get, for the one in the previous slide is from the textbook. And for
Nelson, is it?
the new one, no, the illustrated textbook.
Okay.
And the new one is from article Medscape.
Okay. So can you repeat the new one again?
So the new one, mine is between 150 to 100, moderate 100 to 50, and severe less than 50. Is it correct, Doctor?
I don't know.
Okay.
I have to go and see.
Okay.
Thanks. But Medscape is good reference. If you take it from Medscape is reliable. Yeah.
Okay. Thank you, Doctor. So platelet is a non-nuclear cell. So involved, as you all know, it involves in the primary hemostasis. So platelet develop from megakaryocyte progenitor cells. So the production is stimulated by thrombopoietin. So the mature megakaryocyte will then generate and release the platelet cell into the bloodstream. So the usual half-life for platelet is 7 to 10 days. So the action of platelet, it act by attached to any adhesion molecule which expose if there is any break in the endothelial wall, and then it will aggregate and form the primary hemostasis. After the primary hemostasis, then it will followed by the activation of the coagulation cascade and fibrin deposition to form a mature clot, which called as secondary hemostasis. So a bit epidemiology about neonatal thrombocytopenia. It is not really common in a well newborn babies. So the percentage is only less than 1%. However, for NICU patient, it's quite high, which is around 18 to 35%, and also very high in infant with extreme low birth weight, which around 73%. So among the NICU patient, most of them, 75% of them, having mild type of thrombocytopenia. Only 25% having severe type of thrombocytopenia. Meanwhile, in the extreme low birth weight infants, most of them having severe type of thrombocytopenia. So the etiology can be classified into fetal, early onset and late onset. So fetal basically when it happened during the pregnancy itself can be caused by autoimmune, congenital infection or autoimmune causes like ITP of the mother. And then for early onset means it occur within 72 hours of life. So the causes can be caused by placental insufficiency like preeclampsia, IUGR or maternal diabetes, or prenatal asphyxia, prenatal infection, and TOSH, any DIC, autoimmune or autoimmune causes. For the late onset, it happened after 72 hours of life of the baby. So the common causes is sepsis and necrotizing enterocolitis. Other causes can be congenital infection or autoimmune. So this is differences between early onset and late onset of neonatal thrombocytopenia. So for the early onset, the degree of thrombocytopenia is between mild to moderate. Most of them is between mild to moderate. And for the it evolves slowly over several days and usually associated with complicated pregnancy like preeclampsia, IUGR, maternal diabetes, and the mechanism involved in the early onset thrombocytopenia usually due to impaired platelet production, and it rarely requires any specific treatment. For the late onset, the degree of thrombocytopenia usually severe, which is less than 50, and it have rapid onset and rapid progression within 24 to 28 hours, and commonly associated with sepsis and necrotizing enterocolitis. So the mechanism involved in the late onset is a combination between platelet consumption and also impaired production of platelet. So in the late onset, usually the baby need multiple platelet transfusion. So for the history, among of the important history that we need to take, first maternal past medical history. If the mother had any history of autoimmune disease like immune thrombocytopenia or SLE, and also did the mother take any medication like chlorothiazide, tobutamide or quinine, because all of these drugs can have cytotoxic effect on the fetal marrow, which then impact the production of the platelet. And then any the past obstetric history, we ask the mother any history of previously affected baby like the same event, any history of stillbirth, pregnancy-induced hypertension, eclampsia, IUGR, congenital or prenatal infection. And birth history, we ask any history of prenatal asphyxia or preterm delivery because this group of baby have high risk to develop neonatal thrombocytopenia. So for the clinical features, so firstly, we look at the general condition of the baby. So the baby might appear sick. So if the baby appear to be sick, like ill-looking, irritable, so it can be usually caused by any inflammatory causes like sepsis or NEC. And if the baby had jaundice, hepatosplenomegaly, or any retinal findings, it can suggest the baby to have any congenital intrauterine infection. And then the important thing that we need to see if is the presence of any purpura, petechiae, or ecchymosis. So petechiae is the petechiae is about 1 to 3 millimeter, purpura more than 3 millimeter, and ecchymosis is 1 to 2 more than 1 centimeter basically. So and then in severe cases, if the baby had spontaneous bleeding, the baby might also presented with epistaxis or mucosal bleeding, and also we need to look for any intracranial bleeding sign symptom like vomiting, seizure, lethargy, confusion, or extreme irritability in the infant. And also if the baby develop anemia complicated from the bleeding, the baby might appear as pale. Next, for investigation, we divide into blood, imaging, and others. So for blood, we can do full blood count first to see at the platelet level, and then also we can see the white cell count to rule out any infection causes or inflammatory causes, and then also hemoglobin to see if there is anemia, complication from the bleeding. And after full blood count, we can do peripheral blood smear. So what we want to see in the peripheral blood smear is to see the platelets morphology. So if the platelet size is large, it more suggestive for peripheral destruction of the platelet. While if the platelet size is small, it more suggestive for platelet production problem. Next, we also can do coagulation profile to rule out any
Can you
coagulopathy.
repeat again about the platelet size?
If large, it's suggestive for peripheral destruction. And if the platelet size is small, it is more suggestive for platelet production problem.
Okay, I will ask open a question. Can someone tell me two syndromes? One syndrome has a small platelet and thrombocytopenia, and another syndrome has large platelet and thrombocytopenia. Okay, open question. So I give you clue.
Platelet.
Yes, yes.
For large platelet, is it ITP?
For large platelet, it is
ITP? In the thrombocytopenic people.
no. It is syndrome. It is one syndrome.
Awesome.
CAMT syndrome, Prof?
What is it?
Congenital amegakaryocytic thrombocytopenia, CAMT.
Yes, congenital megakaryocytic thrombocytopenia. No, it is not that one. Westcott-Aldrich. Westcott-Aldrich causes a small platelet, micro thrombocytopenia. What else they have Westcott-Aldrich? They have
eczema,
immune
They
deficiency.
have eczema and
primary immunodeficiency.
immunodeficiency. Very good. Yeah, so they have small platelet thrombocytopenia. That's why we call it micro thrombocytopenia. So the platelets are small and little. Micro thrombocytopenia. Again, they have eczema and they have immunodeficiency. So this is Westcott-Aldrich syndrome. So which one has large platelet and small number? Start with B.
Bernard-Solier.
Yes, Bernard-Solier syndrome. Very good. Bernard-Solier syndrome. Okay, carry on.
Okay, and then we can also do blood culture and sensitivity if we suspect patient to have sepsis. And the dimer rarely done, but it can be done in patient with DIC. And then antiplatelet antibody screening if we suspected infant to have the thrombocytopenia causes by immune. And then TOSH screening because TOSH infection can cause thrombocytopenia. And then imaging, we can do the non-radiative method, which is by head ultrasound to see if there is any bleeding. Usually we do the head ultrasound if we suspect the baby to have any intracranial bleeding, usually in the severe type of thrombocytopenia. Other than that, we can also do karyotyping because some syndrome is said to be associated with neonatal thrombocytopenia. And also bone marrow examination, if we suspect the causes is due to the bone marrow failure, so we want to quantify the megakaryocyte. So if the megakaryocyte amount is few, it indicate the platelet production low. If the megakaryocyte is high, it means the problem is the peripheral, so means that the causes is due to platelet destruction. So next for management, so the choice of treatment is between oral prednisolone, IVIG, platelet transfusion. So actually for management, we can prevent neonatal thrombocytopenia even before the baby delivered. So we can give to the mother, usually we give to the mother with any history of ITP or SLE to prevent. So we can give oral prednisolone or IVIG. And then post-delivery, the choices of treatment is either IVIG or platelet transfusion. However, most of the case does not need any treatment, so we just treat conservatively depending on the severity of the thrombocytopenia. So this is a summary on how the indication for transfuse with platelet. So it is divided into non-bleeding neonate, bleeding neonate, and NAITP is neonatal alloimmune thrombocytopenic. So for the non-bleeding, usually we do not transfuse unless the level is less than 30, which is very low, or if it is more than 30, we transfuse if the patient have clinically unstable or have previous major bleeding concurrent with coagulopathy, or maybe the infant need surgery or exchange transfusion. So in this case, we need to transfuse patient. But if more than 50 and above, we doesn't need to transfuse with platelet. However, for bleeding neonate, most of the case we need to transfuse unless the platelet count is more than 99. And same with NITP, neonatal alloimmune thrombocytopenic. So we need to transfuse unless if the level is more than 99. So however, for NAITP, special things that we need to take note is we need to transfuse with HPA compatible platelet. So next, complication in general, in neonatal thrombocytopenia, it can cause bleeding or hemorrhage. It can occur anywhere in the body, in the brain, GIT, lung, or renal, and if not treated properly and immediately, it can cause mortality to the newborn. That's all.
Okay, any question to Shahira about thrombocytopenia? Any question? Okay, if no questions, we go to the next presentation. Thanks, Shahira.
Thank you, Dr.
Assalamualaikum. Can you hear me?
Walaikum salam, Amirun.
Okay. So I will present for next topic is hemorrhagenesis of newborn. Can you see the slide?
Yes.
Okay. So
Can you hide the sharing?
okay. Alright. So hemorrhagenesis of newborn. This is small outline. Okay, first introduction, epidemiology, classification, etiology, clinical features, differential diagnosis, management, complication, and also prognosis. So, what is meant by hemorrhagenesis of newborn? So now it's known as vitamin K deficiency bleeding, not use anymore hemorrhagenesis of newborn. So vitamin K deficiency bleeding is an acquired coagulopathy secondary to reduction of vitamin K dependent coagulation factors below the hemostatic level. So it's basically deficient in the vitamin K. So before we proceed, we must know what is type of vitamin K. We have three types of vitamin K. First is K1, known as phylloquinone. It's come from our vegetable products, vegetable oil, and also dairy products. While K2 is menaquinone, is synthesized by our gut flora, and also K3 menadione, which is synthetic. So this is mnemonics that you must remember for this presentation. Very important in our coagulation cascade. It's important in factor 2, which is prothrombin, 7, 9, and also 10. So this is easy mnemonic lah. And this mnemonic is also for useful for warfarin, which is also known as anti-vitamin K. Okay, so
Very nice.
this is
Very nice.
okay, so this is
Very good.
the pathogenesis and clinical finding of vitamin K deficiency. This diagram basically summarize of the pathogenesis. So basically, when newborn, they have deficiency vitamin K because first of all, they have reduced receive of vitamin
Amirun,
K.
I can't see the diagram. You said there is diagram. I can't see diagram.
Okay, so first of all, uh, because uh, because in a newborn there was why there was small bowel bacteria overgrowth. First of all, because during first week of life there will be sterile gut, mean there will be no bacteria. So because of there no bacteria, so there will be no vitamin K production at that time. So because of that, there will be decrease lah of vitamin K deficiency. And another reason, because when a mother use antibiotic during the pregnancy, so they will also cause this small bowel bacteria overgrowth. So because of this, there will be disrupt of normal flora and also reduce gut flora synthesis. Therefore, there will be vitamin K deficiency, which is vitamin K2. For as other example is exposure to vitamin K antagonist, like I said before, which is warfarin. So with these warfarins, so they will be that used by the mother, they will be inhibit the vitamin K. So they will be reduce vitamin K, cause the vitamin K deficiency. That will later on for the newborn will cause vitamin K deficiency bleeding. Another example is dietary deficiency and also malabsorption. Malabsorption because of these three features, which is gastrointestinal mucosal disease, pancreatic insufficiency, and also cholecystitis. Later on, I will explain detail about the classification of the vitamin K deficiency bleeding. So from this vitamin K deficiency bleeding, so there will decrease in the clotting factors that I said before, 2, 7, 9, and 10. So because of these defects, there will be decrease in clotting pathway and also extrinsic clotting pathway. For extrinsic will be factor 2 and also factor 7, while factor 10, while intrinsic will be factor 7 and also factor 9. So because of this deficit, so will be bleeding tendency occur during the newborn. So the presentation will be, if involved in GI, will be gastrointestinal tract
Can you say
bleeding.
again which one is intrinsic and which one is extrinsic?
Intrinsic will be factor 10 and also factor 7, and factor 9 and also factor 7. And
No,
extrinsic will be
factor 7
factor
is extrinsic. Factor
factor
7 is
7,
intrinsic, yes.
extrinsic,
Factor 9 is intrinsic. 2
factor 2
and 10, they are in the common pathway.
yes.
Common pathway.
Okay, factor 2 and 10 common pathway, factor 7 extrinsic, factor 9 intrinsic.
Yes, exactly.
Okay. So later I will talk about the clinical presentations. So for next, epidemiologically, so this why currently is uncommon to have vitamin K deficiency bleeding, because now we have vitamin K prophylaxis during first week of life or at birth that be given. So from Medscape, the risk of bleeding when not given prophylaxis is about 1,700 per 100,000 infants, which is 1 of 59 babies. However, when we give prophylaxis, which is vitamin K, the risk is only 1 per 100,000 units. That's why it's very important to give prophylaxis of vitamin K during birth. So classification. So vitamin K deficiency bleeding, we can classify into early onset, classic onset, and late onset. It based on the lifetime lah. So for early onset disease, there will be 0 to 24 hours. Classic onset, 2 to 7 days, the first week of life. Late onset, after first week until 6 months. And this is the common site of the bleeding. For what we afraid for early onset is it involves the intracranial bleeding. And then that's the other common sites. Okay, for the etiology, so basically I divide into fetal, maternal, and also both factors. So for the fetal factors, the first factors will be prematurity, because when prematurity there will be low vitamin K. When low vitamin K will expose to vitamin K bleeding deficiency, bleeding. And also neonatal liver and also have low vitamin K storage at that time. So also predisposed to hemorrhage for vitamin K deficiency bleeding. And also, as I said before, sterile and fetal gut. So there will be no bacterial growth during that time. There will be no vitamin K production. And also other things which is most at late onset, which is malabsorption of vitamin K. For example, biliary atresia, cystic fibrosis, and also hepatitis. For maternal factor, exclusive breastfeeding is also disadvantage because they have lack of vitamin K. However, this can be countered by giving prophylaxis vitamin K later. And then maternal medications, like I said before, warfarin, some anticonvulsive drugs such as carbamazepine, and antimicrobial drug. Most important is anti-TB, rifampicin. And also the both factor, during fetal part, there will be limited transplacental transfer of vitamin K, and also if the mother have inherited coagulopathy. So for the clinical features, for the history part is very important, because what you need to take from the maternal history, you should confirm what the medication used during the pregnancy, if there any warfarin usage or also antibiotics, and also anticonvulsive. And then for fetal history, you must ask if the baby have vitamin K prophylaxis taken at birth, because if not taken, they will be predisposed to vitamin K deficiency bleeding, any antibiotics, exclusive breastfeeding, and also diarrhea. Diarrhea because of malabsorption of vitamin K. For physical examination, usually vitamin K deficiency bleeding, no signs of bleeding. However, if in moderate and severe case, there will be sign of soft tissue hemorrhage such as ecchymosis, like you can see in the slide, and also and then sign of intracranial hemorrhage, we can see through if the baby have bulging fontanelle or any neonatal seizure or apnea. So the other differential diagnosis you may consider, first is DIVC, diameter intravascular coagulation, hepatobiliary disease, neonatal thrombocytopenia that had been explained by Alia, and also hereditary bleeding disorder, for example, von Willebrand disease. Okay. For management part, for the investigation, the most important thing is coagulation profile. What we need to know is prothrombin time and also INR. There will be increase in prothrombin time in factor 2. And also we must remember how to differentiate between the neonatal thrombocytopenia. The platelet in this vitamin K deficiency bleeding will be normal. And when we give when after the bleeding, we give the vitamin K, usually the prothrombin time will be normal back. And then for neuroimaging, if we suspect any intracranial hemorrhage for the newborn. Okay, next. For the treatment, I will divide into early onset, and late onset. So basically, the treatment is only give immediate IV vitamin K, whether 1 or 2 milligram. And if the bleeding is severe, we can give 10 to 15 milliliter of kilogram of fresh frozen plasma. And then for classic onset and late onset, you also use exogenous vitamin K therapy, whether IV or oral. And we must remember not to give IV because intramuscular can cause hematoma at the injection site. Will cause more severe bleeding lah. And folate onset, they will be associated with other underlying causes. So we must treat the underlying causes as well.
Amirun, I will stop you. So here, whatever type, early onset or classic onset or late onset, if they ask you in the exam, if you see baby bleeding, what will you give? The answer is fresh frozen plasma. The reason, because vitamin K will take some time to work. So once the bleeding is there, we have to give fresh frozen plasma in either type.
Or immediately fresh frozen plasma.
Yes, always, in all types. Once there is bleeding, don't wait, give fresh frozen plasma. Because fresh frozen plasma will provide the factors immediately. Vitamin K takes time to work.
Okay.
Okay.
Okay. Thank you, Doctor.
Thank you.
So basically, the for this disease, the best management is prevention, which is intramuscular vitamin K1, K during 1 milligram at birth. Okay. For the complications, so first of all, what we afraid is intracranial hemorrhage. Next is hepatic adrenal gland hemorrhage, and also complication of our treatment itself, whether during IV there will be anaphylactic-like reactions. There will be when given high dose of vitamin K can induce hyperbilirubinemia or hemolytic anemia, and also if I give IMs can cause hematoma. So prognosis for vitamin K deficiency bleeding, it depends on the amount of blood loss, bleeding site, and also gestational age. So in absence of intracranial hemorrhage, the prognosis is good, excellent. But in presence of intracranial hemorrhage, the prognosis depends on the extent and location of hemorrhage. So in intracranial hemorrhage, we must aware of any motor or neurological deficit later onset of the time. And and also in intracranial hemorrhage, the mortality rate also increase. Okay, so that's all from me. This is my summarized table that I get from Nelson that summarize all my presentation. I think that's all. This is my reference. Thank you.
Okay, thank you, Amirun. Any question to Amirun?
Yes, I have one question. I might miss some point. Can you repeat why prematurity can be cause of thrombocytopenia?
Bleeding, you mean?
Sorry, bleeding.
Because there will be basically there will be less vitamin K received by the newborn, so there will be more higher chance to get bleedings.
So less. Is it the same like the sterile guide? No. Is it
it's same lah.
Yeah, the flora, yes, the flora. The flora is not well formed yet. The flora needs exposure to the elementary diet.
So doctor, you said that breast milk contains less vitamin K. So for premature infants, how actually we have to introduce the infant formula for them to avoid the risk of having BKVD?
No, we never recommend formula. We never recommend formula. We give vitamin K prophylaxis and we give enteral feeding. Once the baby is able to tolerate enteral feeding, we give breast milk. We never recommend preterm formula. I didn't see any guideline telling that you give preterm formula to avoid vitamin K deficiency.
So is it the same with the preterm baby also?
Sorry?
Preterm baby, we also not give the infant formula first.
Yeah, we don't give. The recommendation for feeding for premature babies, if they can't tolerate feeding, we give fortified human milk. Fortified means you give breast milk with extra calories to let the baby gain weight, because you know when you give formula, preterm formula, it has high calories, which make the baby gain weight. But we want the advantage of the immunity, the advantage, the immunological properties of breast milk. So what they have made human milk fortifier, which comes in sachets. You mix with the expressed breast milk, so you get the immunological properties of breast milk, and at the same time you get high calories. And for the vitamin K, we give the vitamin K supplement. For the premature babies, they give the injection same dose after birth. Every baby after birth takes vitamin D injection, and after that we can start multivitamins for the babies. By 1 week, if they can tolerate, we can start multivitamins.
Okay, thank you.
Welcome.
Any other questions?
So if no other questions, we finish our session for today. I need Amirun and Ali Shahira to send the changes which you made in your slides. Send to my email, please.
Okay. Okay, doctor.
Okay, doctor.
Okay. I think we have class tomorrow, is it? Do we have class tomorrow?
What class, doctor? I
think in the
think
timetable we have class. Tomorrow is
no, there is no class with you tomorrow. We have class with Dr. Said about neonatal lecture.
I see. Okay, okay. So
Okay.
see you. All the best.
Thank you, Doctor.
Assalamualaikum.
Salam.
Welcome.
Thank you, Thank you, Prof.
Thank you, thank you.
Thank you, Prof.
Thank you all.
Thank you, Prof.
Thank you, thank you. Bye.